All right, everyone. I want to welcome everyone to our neonatal track concurrent session on the incidence and impact of critical congenital heart disease in newborns in Texas. My name is David Wysoli. I am a neonatologist and medical director of a large neonatal maternal fetal pediatric and newborn medicine practice in Houston, Texas. I am really honored to also be co-chair of the TCHMB Neonatal Committee, and I am the RAC PCR Alliance chair. The RAC PCR Alliance is an organization with the 22 Regional Advisory Council executive directors in the state of Texas that cover the entire state, as well as all of the perinatal committee chairs from each region. It is my real honor to introduce our first three speakers for this afternoon session. Our first speaker is Dr. Alice Gong, who is Professor of Pediatrics, Medical Director of the Premier Program, and the Rita and William Head Distinguished Professor of Environmental and Developmental Neonatology for UT Health San Antonio. Dr. Gong's research interests and publications include topics such as surfactant replacement, retinopathy of prematurity, nutrition for premature infants, newborn screening, breastfeeding, follow-up for NICU survivors, and family nurture care in the NICU. Dr. Gong lives in San Antonio with her husband. She has 3 adult children, 3 grandchildren, and 1 more on the way. Our second expert speaking is Dr. Gerard Martin. He is a pediatric cardiologist who has been in practice at Children's National Hospital in Washington, D.C. since 1986. Dr. Martin was promoted to professor of pediatrics with tenure at the GW University School of Medicine in 1995 and was the chief of cardiology from 1997 to 2009 and senior vice president for the Center for Heart, Lung, and Kidney Disease from 1999 to 2015. He founded the Children's National Heart Institute in 2004 and was named the C. Richard Beta Professor of Cardiology in 2007. Dr. Martin is an advocate for congenital heart disease efforts nationally and internationally. He played integral roles in the development of Cchd screening and the subboard of adult congenital heart disease in the United States. Our third speaker is Dr. Charlita Guillory. Dr. Guillory is an associate professor of pediatrics in the section of neonatology at Baylor College of Medicine and director of the Texas Children's Hospital Neonatal Perinatal Public Health Program. She's the immediate past director of the TCH Level 2 Neonatal Intensive Care Unit, having served for over 20 years in that capacity. She earned her Doctor of Medicine degree from LSU and did her fellowship at Texas Children's. Her primary research focus addresses the issue of decreasing Black infant mortality and morbidity. Dr. Guillory is the immediate past chair of the Texas Department of State Health Services Newborn Screening Advisory Committee and is co-chair of our TCHMB Neonatal Committee. In addition, she serves on the Texas Health and Human Services Perinatal Advisory Council. And Dr. Guillory recently had received previously the Texas Pediatric Society Sidney Kaliski Award for many years of leadership as the chair of the TPS Committee on Fetus and Newborn. And it's her passion for promoting public health and a role as an advocate in elevating the many issues affecting these vulnerable populations that were the trigger for her receiving this award. She was recently also appointed to the AAP National Committee on the Fetus and Newborn and is president of the Texas Pediatric Society for 2021 and 22. I'm excited and honored to welcome our first 3 speakers of this session on CCHD. We begin with Dr. Gong.
Thank you, Dr. Wysoli. Could I have the next slide, please? Okay, so the objective of this is to discuss the gaps and challenges in the Texas Critical Congenital Heart Disease Program. Next slide. I want to, I'm basically the background person, and so I'm posing the reason why we feel this is so important to have CCHD be a quality improvement project. Dr. Martin, I'd like to thank him tremendously because without his national effort, leadership, and the publication of the first implementation of CCHD screening in the US, we wouldn't be where we are. The other thing that's important that you should know about is the fact that there is a Texas Newborn Screening Advisory Committee, of which I'm the immediate past president now, but it was actually mandated in 2009. And because of our service on that committee, Dr. Guillory and I participated in a project which we call the TextPop project. And that's led to some of the things that we will talk about. And then another big thank you is to Dr. Scott McLean, who led the CCHD subcommittee for the Newborn Screening Advisory Committee. And that was because we had a parent who came to us who had a child that was missed by CCHD screen in Texas. And in her question to us is, how could this have happened? And we said, well, it does happen because we can't screen except, just before your baby goes home. But the thing that was missing was the education piece that we had focused on when we did our study of how to implement CCHD screening. Next slide, please. So CCHD screening does save lives, and this is just a basic background information. It was based on Dr. Chang's study that was published. Basically what they did was they did a retrospective look and found that when CCHD diagnosis is missed in about 16% of the cases of the kids who died, then that's what happened. They die, and that we could, by screening, pick these kids up and keep them from dying. So next slide, please. So I have to give a big shout out, thank you to Dr. Judith Livingston, who was the coordinator of our TextPop project. She also came up with the name of Texas Pulse Oximetry project for TextPop. Dr. Guillory and I were managed by Dr. Livingston, and with the help of Dr. Deborah Friedenberg, we took on the task of how could we implement this project in Texas? How can we get newborn screening as a point of care done in a state as big as Texas? And we undertook this by gathering different hospitals, level 1, 2, 3, and 4 hospitals together. And with the help of a nurse champion from each one of those hospitals, we were able to do implementation. And we found that by training the staff, we could actually get them to retain the information, understand about newborns, CCHD newborn screening, identify how to do the screening, how to use that algorithm that was approved by AAP, and how to explain this to parents. So that was kind of the process, and this poster shows that. Next slide, please. Okay, so in 2014, we had the legislative mandate, and I have to say that we started our TextPop project before the mandate so that we could have that information in place. The mandate was great. They wanted all babies that are born in Texas screened, and there were a few exemptions, and that is if the parents decline the screening, it is after our Texas. That if the newborn is transferred before the screening process is performed, and then it is up to that facility to perform the screening, that the screening had been done somewhere else. If the baby had been diagnosed beforehand and had a postnatal echo, then they do not need that screen. And for those babies that are born with midwives and so forth, if they're discharged from that facility less than 10 hours after birth, then they have to be referred somewhere else to get their screening. Next slide, please. The unfortunate thing is part of the requirements was that reporting was not done in a manner that we would all like to have. The requirement of reporting was that a physician, a healthcare practitioner, a health authority, or birthing facility, or anyone who has the information of a confirmed case of critical congenital heart disease, then they should report that confirmed case. So it's not that only those cases for which screening was done, but for all cases. And the confirmed cases must be submitted to the newborn screening unit using the most current method, reporting method. So initially it was a fax machine, and now there is a website that's available where people can go in. So that does make it better. But there was no process in the law about data collection, analyzing. So it was it's very difficult. We do not know if all babies born in Texas are screened, so we don't have compliance. We also have no provision for training or recording of data or any type of quality improvement as part of the law. Next slide. So in the process of what we did for implementation for the state of Texas, we developed it with a grant from Department of State Health Services. We developed a toolkit, which is posted on their website, and it is also on the Texas Pediatrics Society website. We had an algorithm. We put it into a small form of a card so it could be available anywhere. People could print that out and put it any place they need it. We did PowerPoint presentations for physicians and for nurses or other staff. We produced brochures, both in English and Spanish, for if there was a positive screen and how to explain it. And we did that also for parents to know about the screen and that the screen is not perfect and what signs and symptoms to look for to take their baby back to be examined. We produce sample orders that physicians can use, and then policies for nursing, as well as screening logs that they can use to keep track. And we develop a very loving video done by Taryn, who was a child who succumbed to a critical congenital heart disease, and her mother was gracious enough to share the story. We also developed a short public service announcement script that we sent to many places so that they can talk about using CCHD screen, as well as a wall poster for the nursery with the algorithm in it so it can be posted. Next slide, please. Unfortunately, the method of reporting that was required did not really work. So in 2014, we had just started, so it was not a complete year. And then you could see each year what reports came into the state, with 2019 being the highest of 261 cases. So when we got this data, pretty much just after the pandemic started, we had close to 1,000 cases over 8 years time period. Whereas we do know from the Texas Birth Defects Registry in a publication that they did, where they did active surveillance, which is after the fact because they're looking at medical charts of children with birth defects. When they looked at critical congenital heart diseases, they found that in the span of about 17 years, there was over 700 cases a year that were found. And so we clearly are not getting the information we need. So we don't know if our children in Texas are screened. Next slide. Okay, so because we had a parent that came to Newborn Screening Advisory Committee and challenged us about the screening, we had a subcommittee, as I have said, that Dr. Scott McLean led that subcommittee. And over 2 years' time, the subcommittee investigated all the possible ways that we can try to make it better. Obviously, we felt the best thing was to change the law, but that would require going to the legislature and opening the law again and seeing if we could get them to change the logistics, provide some costs so that that point of care screening can be reported accurately to the state. That was not feasible, and so, but it was a good thought. And then to maybe not change the law, but to amend the law. And one of the things that we thought might be helpful was to add cardiologists to the reporting, because they're not particularly listed in the list, and maybe they are the ones who have the most information of children. So if they were required to report, we might have better reporting. And then the last thought was, why not use make it a quality improvement project? And at the time, we knew about TCHMD and that what they were doing, and understood that the regional advisory councils were going to merge with TCHMB, consequently giving them access to all the hospitals that are delivering, or to use the levels of care designation and ask them to require CCHD screening, so that when they are reviewed, we could find out if they were all doing it. So those are some ideas. And now those ideas were actually sent to Dr. Hellerstedt from the department, which he thanked us for and said that he would share the information with TCHMB as well as the regional advisory councils to see if they can use quality improvement as a way of promoting CCHD screening, not just the screening, but making sure that we do quality screening and that we are following the guidelines. And I'm going to cede the rest of my minutes to Dr. Martin, because I know he has a lot to tell us about what is happening in the country and internationally. So thank you very much.
Thank you, Dr. Gong, and thank you, Dr. Wisely, for starting us off this afternoon. I'm honored to speak to the Texas Collaborative for Healthy Mothers and Babies, and listening to Dr. Gong, I think many of the things that you're learning about screening in Texas are issues that have been reported across all 50 states, and of course even in the District of Columbia. So I think turning this into quality improvement is such a strong commitment by the practitioners there, and I wish you all the luck in the world. We have our first slide, please. What I hope to do in this, advance one more, during this short period is to let you know about the current status of screening and implementation in the US. Next, please. And understand reasons for the recent recommended changes to the current AAP endorsed protocol. Next, please. And to recognize the improvements in mortality that have been attributed to CCHD screening in states with mandatory screening. Next, please. Now, I always start off with this slide because I think it just sets the table, just in case there are some people not familiar with congenital heart disease in the audience. And that is, congenital heart disease is the most common birth defect. This is a study that was done by Dr. Hoffman back in 2002 and published in the Journal of American College of Cardiology. And he looked at all of the studies looking at the prevalence of congenital heart disease. And he found that the most frequent number cited was right around 8 babies per 1,000 with congenital heart disease. Now, the incidence or prevalence really varies depending upon the inclusion criteria. If you look at babies having treatment during the first year of life, it's only about 4 per 1,000, and that was shown back in the New England Infant Regional Cardiac Program published by the Boston Group. If you look at babies that have echocardiograms in the first year of life, it's probably closer to 10 per 1,000 or 1 per 100 number. But the critical defects, the number that is most often quoted, is about 3 per 1,000. And these are babies that, if they're not found during a certain period of time in the first weeks or months of life, these are babies that can die at home or become incredibly ill and suffer neurologic injury that will complicate not only their initial treatment, but their developmental outcomes throughout childhood. Next slide, please. And pulse oximetry has been around for a while. The early studies were back in the around 2000 to 2002, where basically pulse oximetry was a concept. And this was led by neonatologists. The first study that I'm aware of was at the Johns Hopkins Hospital in Baltimore, where they added pulse oximetry at their nursery. And they said that they found a few babies that they would have missed and that this would have been helpful. There were some other studies up in Long Island and in Florida, but basically it kind of fell off as being something popular in the US, but it got picked up in Europe, mostly in the Nordic countries. And that's where really the proof of concept came in, that this was a valuable test. Next, please. Now, in 2009, the American Heart Association, American Academy of Pediatrics wrote a statement, a scientific statement, where they said, you know, it's probably valuable, it might be helpful, but we're not quite ready to say that it should be done for every baby. And this really caught the eye of some parents, and it caught the eye of the Health Resources Administration Secretary Advisory Committee on Heritable Disorders in Newborns. And so after feedback from especially parents, they held hearings in the summer and fall of 2010. And there was a lot of testimony from experts about what they thought could be done if this was added to the newborn screening panel. There were parent testimonies about what happened to their child with delayed diagnosis. And as a result of that, they thought that there should be further effort moving forward. And that's where the first stakeholder meeting in January of 2011 came from. And in this meeting, we brought together scientists from the various medical groups, AHA, AAP, ACC. We had scientists from FDA, NIH, CDC, and we looked at the data. We had some of the leading scientists there from Europe, Dr. Granelli, Dr. Ewer, as well as US-based scientists. And this is the paper that Dr. Gong referenced, where we came up with what would then become the AAP recommended protocol. Next slide, please. From that recommended protocol in 2010, a lot of work started getting done to actually go back and work with 2011, to go back and start working with the AHA, AAP, AAC, ACC to get them to sign letters in support of this. Those letters with the Secretary's Advisory Committee report all went to Secretary Sebelius. Rodney Howell was a tremendous committee chairperson for the Advisory Committee. And despite what at the time was probably a little pushback from the White House, where they wanted no unfunded mandates, Secretary Sebelius recommended it. The White House let it go through, and we were off and running. Next slide, please. This led to a second stakeholder meeting that was again held in Washington. And this is where we really started looking at what data should be reported, both at the local level as well as at state level. We looked at the importance of education. We looked for issues that were going to be problems for local care providers and departments of health. Next slide. The Secretary Sebelius asked the CDC and NIH to come up with a research program and to look at the impact of implementation. So they came up with 6 states. It actually was more than 6 states. In New England, there were probably, I think, 4 states that made the New England Collaborative. So there were these demonstration programs that were funded by the government. And basically, they all met at our hospital in Washington to learn about screening and to figure out how best to get started at their state level. Next slide, please. Needless to say, what happened next, we finally got formal endorsement from the American Academy of Pediatrics. This was signed off by American Heart Association, ACC, and this was all very helpful because then it led to what was, I didn't understand. I thought once the Secretary Sebelius said do it, it was simple. But the next slide shows what really needed to happen. Next slide. Basically, the government, look back one, please. The government, and based on scientific evidence and professional endorsement, can kind of make a recommendation, and that's what the advisory committee does. But really, each individual state needs to make a decision on whether to require a newborn screen. And so what it then required is basically all 50 states we needed to move from just saying it was going to be valuable to actually advocacy to get this law passed in 50 states. Next slide. So that started. Indiana and Maryland were the first states to pass screening. I can tell you my experience in Maryland, this day was over where we got it signed, I said I would never again do anything that had to do with government. It was so hard to get a law passed, which we thought was going to be so easy. And we were fought by Hospital Association and we were fought by the Department of Health in Maryland. And their reasoning was they didn't have the resources to ensure that it was done right. New Jersey passed a law a little bit later in 2011, and actually they were quite brave. They said not only, it was like they gave New Jersey's hospitals 1 month to implement. So in 2011, there were only a few states that were actually screening. And what is impressive is that by 2018, so it took 7 years, and in 2018, Idaho became the final state to sign on so that we had legislation in all 50 states and the District of Columbia. Next slide, please. We kept working with the American Academy of Pediatrics on lessons learned, this paper with Matt Oster taking the lead. And one of the things is we felt that not all the conditions initially listed by the American Heart Association were the only conditions. They had 7 conditions basically. And so we expanded their list up to 11 conditions. And some people would like it to go to 14 conditions, but not only do we talk about core conditions, those that are truly critical congenital heart disease, but we identified the secondary conditions that are actually in most centers picked up more often than the heart defects. So this is, I think, why neonatologists became so supportive, because it was one thing to find the critical congenital heart disease, but they were finding the other conditions, babies with early infection, lung disease, non-critical congenital heart disease, PPHN, hemoglobin abnormalities. And so basically, I think depending upon the region, there's probably 3 or 4 of these secondary conditions picked up for every CCHD. Next one, please. This is the standard protocol recommended by AAP, and I show it because it's it required 2 retests before you actually said someone failed, unless you had a pulse ox less than 90%. But it was confusing and it was hard to follow. Next slide, please. And in fact, not all states followed it. New Jersey came up with their own. They thought it was silly to have the either or, that the SAT could be greater than 95 in either the hand or the foot to pass. They just said, why not have them both be greater than 95? And Tennessee wanted to really simplify it. They said you could just screen the lower extremity, and if you picked up a SAT difference in the lower extremity, that was going to be indicative of a baby with congenital heart disease. Next slide. So we do have confusion. This leads to, if you take a picture of the United States, the purple shows where the AAP protocol is required by law. It's really a minority of the states in the purple. In the orange, the AAP protocol is recommended but not required by law, or it's at least referenced. And the gray states are states that just say you should screen. So there's really 3 groups of states currently. Next slide, please. So we met in 2018. We brought all the characters back together and said, what have we learned? What can we say was a success? And what can we do to make it easier? And the first thing to make it easier, we all decided, was that we could drop the second retest. Data from Europe, data from Georgia, and now currently data from a hospital that we work with, Holy Cross Hospital in Maryland, have all shown that the increase in false positives by doing a second retest are minimal. The number of false positives from auscultation and hearing a murmur and calling from a cardiology consult are far greater than the false positives from pulse oximetry. So by eliminating the second retest, we felt that babies would get into a evaluation mode faster, and they would get into a treatment mode faster. The second thing we did was, not on the basis of tremendous scientific evidence, we looked at the changing it to 95 in both the arm and the foot. And we just thought it would be easier for states if we recommended that. And so that change was made. Next slide. And so this is the current recommended protocol. It's due to be reviewed by the AAP to get endorsement. Next slide. The biggest thing is this slide from ABUC and the CDC group, which looked at the difference between states that had no policy and those states that had a mandatory policy. Next slide. Next slide. Sorry. And next slide. States with a mandatory policy saw a decrease of 33% in deaths from critical congenital heart disease in the first year of life. And they saw a drop in mortality by 21% in other congenital heart diseases. So it clearly showed evidence that we were making a difference. Next slide. So our problems, there's been plenty of successes. There are still difficulty and we're having fewer deaths, but we're still having difficulty quantifying the outcomes of screening. Next slide. And so we're hoping that people will work with the New Steps team and the APHL. This may be something for Texas. In a more organized way. And so thank you for allowing me to speak to you today. And I think we're passing it to Dr. Guillory.
Thank you very, very much. Good afternoon. And thank you, Dr. Gong and Martin, for the excellent presentation. As you clearly laid out the landscape for CCHD screening in Texas, the US, and internationally. You have demonstrated the effectiveness and value of CCHD screening as a vital safety net in saving newborn lives. My focus, if you go to the next slide, please, will be on improving the quality of CCHD screening in Texas, utilizing quality improvement initiatives. The next slide simply reiterates what Dr. Gong has said, and it is so important that you understand what Texas law states about CCHD screening in Texas. It is an unfunded mandate that all babies are screened, and it is an unfunded mandate that all confirmed positive cases are reported to the state newborn screening program. If you look at the next slide, this shows you the required CCHD reporting form, and it's located on the Department of State Health Services website. Note that it collects data of race and ethnicity. It collects data on diagnoses, both pre and postnatal echoes, if a baby was transported. And most importantly, it also depicts whether the diagnosis was made with pulse oximetry. The next slide, please. With this, the next slide, please. With this required data form being the only state collected data by the state on CCHD screening, we attempted to determine CCHD compliance. And actually what we obtained from the AEP was a list of 392 birthing centers in Texas and their medical directors. 380 people responded. We developed a 10-question telephone survey and administered it to the directors or their designee, and about 92% said they were screening the apparently healthy newborn, and approximately 70% of the birthing hospitals were screening for NICU 2, 3, and 4 babies. 75% of them did admit that they used the TextPop tool screen as a guide. The next slide shows the reporting. Next slide, please. Go to the next one. It shows what Dr. Gong said about the number of cases that are being reported to the Department of State Health Services. If you look at the next slide, you will see that the reporting facilities vary quite a bit. And this really helped when we looked at the data. It helped the Newborn Screening Advisory Committee recognize that the law says you must report it, but they did not say who is the designated person to report it to. So we actually had to look at that, and that was one of the things that we knew we could make an improvement on. Next slide, please. The Texas Birth Defects Registry is critical to Texas screening for CCHD. On the next slide, you can see that the Texas, that the CDC gave to the Texas Birth Defects Registry a supported surveillance activity grant. And this grant purpose was to explore comorbidities and developmental outcomes identified within and outside inpatient hospitalizations for patients with CCHD. The Birth Defects Registry also gathered information from social workers to identify the utilization and barriers to service. Since April of 2019, social workers have reached 86 children with CCHD and their families and made referrals to programs for these families. And very importantly, as we look forward in the state to do quality improvement projects, the Birth Defects Registry received the same grant again for another 5 years. So they will be able to delve quite heavily into CCHD. Next slide. Real quickly, you can see on the slide here for the Texas Birth Defects Registry you can see by year the number of cases of critical congenital heart disease that was reported by the Birth Defects Registry every year. And when you look at newborn screening, by the way, it's also an active way of looking at it because people are filling out the forms. But I want you to pay attention to year 2015, where the Birth Defects Registry identified 715 patients with critical congenital heart disease, yet the newborn screening advisory committee forms that were turned in was only 174. So you can see the Birth Defects Registry, which is an active surveillance registry, is very critical to us being able to identify cases and pick up additional cases that might be missed in the program. Next slide, please. Well, where are we with CCHD screening in Texas? We know it's required by law. The law legal mandate is flawed because it provides poor mechanisms for determining the effectiveness of CCHD screening. We actually screen with pre and postductal SATs within the first 48 hours of life, but these measurements are not communicated to the Texas Department of State Health Services. The degree of compliance with the legal mandate is unknown, and the end result is ineffectiveness of the CCHD screening program are unknown what is actually happening in the program. The next slide, please. Texas law does require confirmed cases be reported. This is not being done effectively, and the number of reported cases falls short of statistical projections. There are large disparities among reporting institutions, and even though, as Dr. Gong said, the TextPop toolkit is on both the Department of State Health Services and the TPS website, it is voluntary and its use is unmeasured. The next slide, please. Well, the problems are we need a mechanism to verify that all infants are being screened for CCHD in Texas. And we need a process to measure compliance or standardization of the screening protocols. Next slide. The questions are, what are the challenges faced throughout the state regarding CCHD screening? What are the barriers to reporting positive cases? Next slide. One of in terms of recommendations, as we look forward to developing a quality improvement project for Texas, we really do need the Birth Defects Registry to compare our CCH data to, and we need detailed analysis of the process of conducting and documenting the point of care screening, especially using electronic medical records. The next slide. We also know that CCHD screening education efforts have to be part of our quality improvement project. We know we need statewide collaboration, and the Texas Collaborative really to help develop a quality improvement project would be really critical in our expansion of this. Next. Well, I'm not going to say anything about the screening, and I'm trying to go a little faster to make up a few minutes here, but the screening for CCHD needs stakeholders. And these are only a few of the stakeholders that are mentioned in Texas. And as was said before, the collaborative with the RAC and PCR Alliance is critical because they provide 22 regions with a representative from each region. And actually, they're acting like champions for this project. And they provide the infrastructure to be able to expand the quality improvement project throughout the state. The Birth Defects Registry I've already commented on and its importance. The Newborn Screening Advisory Committee, as Dr. Gong said, actually presented this to the collaborative as a quality improvement project. But don't forget the Perinatal Advisory Committee as we deal with the state developing levels of care, leading states in that level of care development. It would be important to be able to look at it and be able to move that forward if it's one of the requirements for designation. Next one. Okay, I'm not going to spend a lot of time on this, but I want to just quickly talk about the quality improvement for critical congenital heart disease screening. And thank you, Dr. Martin, for all the work that you have done. And in this particular quality improvement intervention, we looked at different places all over the states. The first one was in California, and we looked at California data, and it basically showed that their screens were not being really presented to the state as well. Only a third of California screens were reported, and a half of the 2/3 that were remaining had inconsistencies. This quality improvement project, you can actually look it up. It was done at the Washington National. And if you show the next slide, I'll just quickly give you the results. It's important to note that any quality improvement project we do must be able to screen every baby. And this one particularly worked on improving documentation and improving protocol adherence. The next slide. Really showed by doing this through electronic medical records, they were able to show decreased documentation in errors from 23.5% to 1.2% and violations from 2.1% to 0.6%. The next one. This is just the minimal core data that any quality improvement project needs to have, and you can read them, but these are the bare minimum data that we would need in collecting quality improvement measurements, and we can easily collect these in a electronic medical record format. Next slide, please. Lots of lessons learned. We've already mentioned them, so I won't go into detail. Next slide. But the most important thing is we look at our quality improvement project that we're proposing, that we relook at the algorithm, as Dr. Martin said, look at surveillance and perhaps using a public health surveillance format to get the word out, as well as making sure that the data collection and surveillance is important. And next, I want to just say thank you. I did that, I think, in 11 minutes, but I look forward to improving the CCHD screening program in Texas. The CCH data reporting is deficient and incomplete, and data incorrectness leads to missed cases of CCHD. We need to have a monitoring, screening, reporting, and improvement in our data reliability. And this is urgent because, as the team before me said, this means we're missing lives. So thank you for the opportunity to speak, and I did that in 11 minutes. Okay, thank you guys.